Hey everybody, welcome to Bumps, Babies, and Boobs. Today we're talking about expecting during COVID, and I have two of my absolute favorite people who are joining me from Bellegrove OBGYN. We're going to have Dr. Keely Brown and we're going to have Dr. Dionne Gallagher, and they're obstetricians with Bellegrove OBGYN, and we're going to answer all your questions on what is it like to be expecting during a pandemic. I don't think anyone expected this to be going on, let alone to be going on as long as it has been. And with the perfect push, I've had so many moms ask us so many questions around, should I stay with my OB? Should I stay with a hospital? Just all these questions has been absolutely insane. So I'm going to start by pulling in Dr. Brown, and then Dr. Gallagher is going to be joining us shortly. We are all home with our kids today, so y'all just gonna have to bear with us. We're working moms, and you know how it is. So, hey, Dr. Brown.
Hi.
How are you?
I am hanging in there. How are you?
Hanging in here with these kids. Dad is at a board meeting, so at some point in time, somebody's gonna show up doing or saying something inappropriate. I'm just hoping Tana has his clothes on. That's all I can hope for.
There might be a naked 5-year-old at some point. It's entirely possible. Bedtime is approaching. We'll see.
There you go. So you're one of the obstetricians at Bellegrove OBGYN. Tell us a little bit about your practice. How long have you been there? Tell our audience about you.
So I have been at Bellegrove OBGYN since 2008 when I finished my residency. So I guess coming up on 12 years now. We have 7 physicians, 6 of whom do OBGYN, one of whom does GYN only, and then we have 2 nurse practitioners and a physician's assistant. And so we are a fully independent private practice. Our privileges are at Overlake Hospital. That's where we deliver and do surgery. And it's great.
Nice.
Yeah.
Welcome to Bumps, Babies, and Boobs. I just love it that you agreed to do this with me. We happen to work together quite a bit with the doula practice.
Yeah.
So yeah, I mean, truly you're one of my favorite people. So I love having you here. I'm going to go ahead and pull in Dr. Gallagher. Hey, Dr. Gallagher.
Hi.
How are you?
I'm good. How are you guys?
Good, good, good. Welcome to Bumps, Babies, and Boobs.
Love the name.
So you're also one of the obstetricians at Bellegrove OBGYN. How long have you been there? Tell us a little bit about yourself before we get into it.
So I have been at Bellegrove for, since 2012. So somebody can do the math on that, like 7 years. And sorry, I'm at home with little ones and I'm not aware of what I'm doing here. And I have known Keely Brown for a lot longer than that. Dr. Brown, we actually both trained at the University of Colorado in Denver together, starting in 2004 through 2008. So
we go way back.
There in Colorado for a little bit before. I'm so sorry. I'm at home by myself.
Oh, no, don't be. No, this is life. So don't worry. We're just talking about how my 3-year-old will probably pop around naked anytime now. So
yeah. So anyway, I have been out here. I practiced in Colorado for 4 years and then came out here to beautiful Seattle because I had gone to medical school out here and my husband and I both love the area and just wanted to be back in Seattle. So thankfully, Dr. Brown had a great practice at Bellegrove and I joined her and the rest of the group over there and have been here since then. So.
Great. Well, it's really great to have you. Thank you for coming on Bumps, Babies, and Boobs. But let's get into it because I know I've gotten a lot of questions from moms who want to know what the heck is going on. I mean, COVID happened and it feels like everything just kind of blew up. And especially when you're pregnant, I mean, just the anxiety women have when they're pregnant and now this. So what changes has your practice made since the pandemic started? What can women expect when they come to Bellegrove?
Keely, do you want to take that one?
I'll
COVID ambassador.
I was the COVID queen when we started dealing with this. So we kind of tried to follow along with Overlake's lead. One of the things that we did was we began to limit visitors into our office to limit our exposures. We also have a universal masking policy. So we are masked at all times and we ask our patients to wear masks. We're cleaning everything. We already cleaned a lot and now we clean even more. We are trying to keep our waiting room relatively empty. And so the doctors are making an extra special effort to run on time and to book so that we can run on time, so that people aren't sitting in the waiting room waiting for us, which keeps you safe and keeps us safe. And so I think those are the long, am I missing anything? I feel like those are the things.
I think the biggest things that we're doing is just masking, washing more. We have not had, and I tell all my patients this as well, like I have been in a mask. At first it was an N95 and then since then it's just been a regular mask, but I've been in a mask since the second week of March. And so has basically the entire office. And we have not had a single staff member that has been sick. So I think there's a lot to be said for the fact that, the governor and everyone in the state of Washington is being told to wear masks, because I really think whether they're a cloth mask or a medical mask or an N95, they are like the absolute key to keeping people from getting sick. And, the hospital has also done a really good job. I think Overlake has been kind of above and beyond from the very beginning in making sure that we have enough. It's not always the perfect amount of, protective equipment, but it's always enough to keep people safe.
Yep.
So that's really just the key. And out in the community, that's all that people need to do, is they just need to stay away from other people and they need to wear their mask and wash their hands when they do have to go around other people. And it's not fun. And it's not very when you're having a baby and you want to be around all your people and enjoying your family, it's not what you want to be doing, but it's unfortunately kind of just what we all have to do right now.
Yeah.
Now, one of the things that, when you're limiting people that are coming into the clinic, it also includes significant others. Mm-hmm. And I get it, but I don't get it. It is, oh my God, how are you dealing with that? And how was the backlash in the beginning? Because honestly, the nurse practitioner in me, healthcare person, is like, I get it. We need to keep you guys safe so that you can take good care of me. Mm-hmm. But I can imagine being an expecting mom and not having the hubs there for every appointment, even though he's probably like, Lord, I don't have to go. But
a lot of FaceTime. We do a lot of FaceTime.
Well, he can be there. That's the whole thing. He can be there. And you know what? Honestly, when you're sitting there in your first prenatal visit and your husband is sitting there, he is super uncomfortable when we're like, okay, it's time for the exam. And then we get to look at the baby. Yeah. And so now it's like, okay, bye, honey. We're putting you down for just a minute. Okay, you're back. There's the baby. It's actually way better. And he's just hanging in the car, probably checking his email during that time. And in some ways, I think patients like it better too. I mean, the hardest thing is honestly the ultrasounds, but if we brought all the husbands and family in for the ultrasounds, our poor ultrasound techs, who are both in a slightly higher risk category, they're both very seasoned and great ultrasound techs, we just expose them 3 times more by bringing in grandma and dad, to every single patient that they see. And then they take that home and expose their family. And so it's just not really fair to do that. But I really feel like FaceTime has been key if people will just, do that.
Do what they say. Well, this is coming from one of the audience who says, I'm Dr. Brown's patient, currently 35 weeks pregnant, and confirm Bellegrove has been fantastic with safety protocols in their clinic. So, I mean, whatever you're doing, work, because there you go. Your patients are appreciating it. But I was just thinking about it in my mind, and I'm like, how, I get it, but
I think the other thing to keep in mind is that we also, and when you asked me what we did that's different, and I forgot to mention one really important thing, we do a lot of telehealth now. Mm-hmm. And so one of the things that I think has been great about adding telehealth to our repertoire is that now I can meet on telehealth with a husband and a patient, or a partner, a significant other and a patient, and include them in that. And so we can have visits together, even though we're not together in the same room, we can all talk together. And I think that's been a vital part of the practice. I've been getting a lot out of that, and I think my patients have too. the other thing to keep in mind is that one of the things that we know about COVID is that it's not just like one viral particle that gets you, right? It's prolonged exposure over time, right? So I had an exposure early on before any of this was like a thing. And it was all fine. I didn't get sick. I was lucky. But when I called, to find out what I needed to do, they asked me a couple of questions. They said, how long were you in the room with the patient? And how close were you to the patient? And our rooms, like all exam rooms, are not big. And our ultrasound room is especially not big because there's all that equipment in there. So you're kind of close to each other. And so when we're talking about patient after patient after patient with partner after partner after partner, that's a lot of exposure in a small room for a lot of time. And so people have to think, what we ask people to think about is that it's not just them, it's all of those people all day long. And so and we are not people, our ultrasound techs and the doctors and the nurses in our office are not sort of replaceable in the sense that if they get sick, there isn't somebody on deck waiting to take care of them. We can't just bring in another doctor or bring in another ultrasound tech. We are specialized. And so because of that, we have to protect, because if we get sick, there's nobody to deliver the babies. And it's really important. And so I think we ask our patients to be really patient with us and to understand, so that it's not because we want to keep everybody out. It's more that we want to keep everybody safe and we want to be there for you when you need us.
Mm-hmm. You want to be able to come in. Yeah. And I think especially with the specialized, practices like yours, a lot of people, you want to have your provider there, right? You want to be able to, if I'm going with Dr. Brown, I want to be able to see Dr. Brown. I know as women get further along, they do get appointments with all your providers, or at least try and get as many of the other providers just in case, because you never know what's going to happen. Mm-hmm. But it is nice to know that you've got your provider and you're going to see them. And if you go out sick, then that's going to change too. Do you think with telehealth being, because I've even found in our practice that there are a lot of things that I'm like, even when life goes back to normal, did we really need all these in-person visits?
No, it's actually been really eye-opening. It's been wonderful actually to realize what we can do. And especially my patients who childcare is a problem to come to visits, or they're working and they just need to have a quick visit. There's a lot of things that we can do over telehealth. And so, part of that is, there's an insurance industry problem that it may not, we're trying to lobby to have that continue beyond COVID, but for right now, it's okay. So,
yeah, I think that is something that's just going to change, whether it's, doctor's appointments or even just employment in general. I just don't think we need to be going into the offices or going into doctor's offices as much. So should pregnant women be particularly concerned about getting COVID?
It has been shown now, the American College of OBGYN has now come out with a statement stating that, as with other infections, pregnant women, because their immune system is somewhat suppressed, they do have an increased risk of getting particularly ill with COVID. And, the biggest problem is, too, that we still don't have any kind of reliable treatment for it. Aside from supportive care, basically Tylenol and oxygen, there's not a ton of stuff that you can do. And the other thing that's interesting that we figured would come out eventually, but pregnant women, because of the large belly and the lung compromise that happens with that, especially in the third trimester, you do have lung compromise basically at a baseline. And so when what can happen with COVID is the lungs can have what's called ARDS, or acute respiratory distress syndrome. And so basically they can fill up with fluid and then they don't exchange oxygen very well. And now you've got this huge pregnant belly pushing up on all that. And you can imagine you're taking your lung volume, which is already compressed, and then you're filling it up with fluid and you've only got so much left. So the good thing is that the age range for most pregnant women and the health of most pregnant women is good. So they're more likely to not get as sick, just purely based on the fact that they don't have whatever it is that we don't totally understand yet about COVID that makes people in that 60 and up group, who, especially with comorbidities, high blood pressure and diabetes and things, get sicker. But then, so they may not get to the point where they need the ventilator, but if they do, they're in bad shape because they've already got a lot of compromise. So
we're also figuring out now, there's a lot we don't know about COVID. Obviously it's a new disease, and women ask me all the time, so what happens if I get it? And it's like, well, you could get sick. But then the next question is, because women are more concerned about their baby often than they're concerned with themselves. And they said, well, what's going to happen to my baby? And the problem is we don't really know because we don't really have a lot of data yet about what happens with those babies. What we do know is there is a good possibility that of what we call vertical transmission or transplacental transmission from mommy to baby. Not always, but there's just recently in the last couple of days, there's been some new, it was a new study that came out that showed that there was some vertical transmission.
Wow.
Not always. And so we don't really know about why that happens or when or how to predict that. But I couldn't, if somebody asked me now, maybe in March or April, somebody would have asked me, could my baby get this? And I would say, oh, I don't know. Now I can say, well, yeah, it's definitely possible. And so we really have if you're choosing to get pregnant right now, then you really have to take, an interest in protecting yourself and protecting your family. Right. Yeah.
That's me. Cause I'm like, literally, I'm like, can this happen? Like this, can we get off this call so I can work on making this baby? We're gonna go.
I mean, I don't want to keep you busy.
That is the life I am living. Cause Dionne, you just talked about, women and age range, mostly we're healthy. I am banging on 40 soon and thinking, okay, already that's putting me in this high risk category, advanced maternal age. So, and then it's funny when you talked about acute respiratory distress syndrome, it never occurred to me that just because you're pregnant, you already have that lung volume compromise. So if you end up getting sick, just like if you get the flu, if a pregnant woman gets the flu, it's not good. Now I'm sitting here thinking, so should women be planning to get pregnant right now? Is it like,
I think I have this conversation a lot every day about should I get pregnant or not? And the bottom line is that life is short and reproductive age is even shorter. So, COVID may be around in a long time. We don't know. This may end up being the next, influenza virus where every year there's a new strain and we've got to deal with it. And so we just don't have enough answers. And I don't think that especially people who are a little bit older, 35 and up, I really don't think that you can afford to wait 2 years to see, because it's really about 2 years. I mean, we're looking at maybe having a vaccine by sometime next year. And then is it actually going to be effective? We don't know. And so I think in that light, and you don't really have to do anything different. You need to do what we're all doing right now. You need to wear your mask. You need to wash your hands. You need to stay away from large gatherings. And I know that's really hard, but you kind of just have to do it. And if you do that, you can get pregnant because you're not going to be putting yourself really at any additional risk other than the doctor's appointments, which, like I said before, we've been really, really successful in not having anybody get sick in our office that we feel like it's completely safe to get pregnant. It's just, you have to be careful.
You have to make a commitment that you're going to do the things that you should be doing, right? You can't get my favorite thing to say right now is everybody's tired of COVID, but that doesn't mean it's over, right? Exactly. And that fatigue, that I'm tired of it, so I'm just going to go do other things. If you're pregnant, and you're choosing to get pregnant, then you have to say, I don't get to make those choices, and I'm going to stay strong, and I'm going to be vigilant about my health and my family's health.
And I guess,
what are you telling women? No, go ahead.
I was just going to say, if you have a particularly high risk job in trying to think exactly what that would be, obviously, in the retail industry and in the restaurant industry, and those are a little bit more difficult because you're going to be in situations all day long. If you're a server at, a local restaurant where people can't mask while they eat because you got to use your mouth. So, in those settings, you might say, we really want to start a family. Maybe this is time for me to get out of this industry and try to look into something else. I mean, there are situations where if you have the ability to take that time to make that plan, that might be in your best interest because you can only protect yourself so much in those situations right now. I mean, maybe it will get better as we learn more about this, but that's the only setting that I can think of where you have to kind of reevaluate, like Dr. Brown is saying, you kind of, even though you're tired of it, or even though, it's not convenient, you may have to actually make choices about getting pregnant versus, now versus later.
Later. So what are you telling women who do need help with getting pregnant and fertility treatments have been put on hold? The clock is ticking. I had a mom tell me the other day, she's like, I can't wait for the grass to grow. I'm like, 39 going on 40. And she had a complicated pregnancy with her first. She lost twins between that. And now she's trying again. And she's like, Rue, and there's COVID, but I can't wait. But I'm being told, we can't give you this prescription. You need to come in and see us. And I'm going to miss a cycle. And so what's going on with fertility treatments? How much of that are you guys doing, or are you guys taking on with like Pacific Northwest, taking a break, Seattle Reproductive, just a lot of policy changes? How is that affecting Bellegrove, and what are you guys doing to address it?
I think I think at least some of the fertility offices are now back. They did take a break, mostly because the governor said you have to take a break. Right. And we also stopped doing some well woman care for a while, the kind of non-urgent stuff. But now I think things are back. I do think that because there's been a long hiatus, there may be some, women may see it as, why are they making me come into the office? And I'm not we don't do a lot of fertility in our office. We do a lot of evaluation to see if they need a fertility doctor. But I would say that if I haven't seen somebody in, 4 or 5 months, and now we're going to be starting this whole new journey, that it might be good to touch base again, before we begin. And that may be where the doctor's coming from, just wanting to make sure that the plan still exists as we know it and that nothing has changed.
Mm-hmm. And, and we do some basic infertility. We definitely do the workup in our office, because we can often do that a little bit more economically for the patient. But we do the workup, and then I've been referring people consistently for the past month and haven't had any issue with people getting in to see the fertility docs in the area. So I don't think that that's a huge issue right now. I do know that they're running pretty normally from what I can tell. As far as what we can offer in the office is, kind of basic fertility workup, and then basic fertility treatment. Once people graduate from that and need things like in vitro fertilization and whatnot, that's kind of.
And IUIs, anything that's invasive or procedural, we don't do. There are only certain situations with certain medications.
Mm-hmm. Yep.
So next question is, say if a woman catches COVID at any point in their pregnancy, should they reconsider if they're planning an at-home birth or a birth center birth?
Yes.
Mm-hmm.
There's one of the things that we know about COVID. Oh, I saw a cutie. One of the things that we know about COVID and has been well documented is that while the disease itself, while you're, COVID positive, may only last for a certain, short period of time and may be over, that there are longstanding sequelae that sort of come after, that people are deconditioned and fatigued and their lungs don't work super well. And we already talked about how pregnant women's lungs already don't work well. And if they're damaged from COVID, then they're going to get into trouble more quickly. And if they're at home or in a birthing center where, a higher level of care isn't immediately available, that's problematic in my opinion.
Mm-hmm.
Yeah. And I guess really somebody who has COVID isn't a good candidate for a birth center or a home birth. But it brings me to my next question, because I think a lot of women have been running from the hills. A lot of women are like, we're not going to a hospital. And people are like flocking birth centers and home and considering home births. And what would you say? Because one of the things that I will say about you, Dionne, when people ask me about you, I'm like, she has a very strong inner midwife. So,
she does.
I love that.
Yeah, she's like an MD, but I kid you not, in another life, she really was a midwife. So every time patients are kind of talking to me and they're like, I want this, I want that, I'm like, I think I know who you want to, who you need to talk to. She is like a midwife, at heart. And then when I have my patients who are like, Rue, this is bugging me, I'm worried, and I'm like, have you met Dr. Brown? She can whisper to any anxious mama, and she can get everything together in a really compassionate but real way. So, which I appreciate about both of you. Mm-hmm. But yeah, so what would you say to people right now, to our moms who are running for the hills and going to birth centers and saying, we're not coming to OBs, because we all know you guys just want to give us a C-section. We know how you guys roll.
No.
And we have one of the lowest C-section rates at Overlake. So yeah, it's in our group too. It's not all OBs that want to do C-sections.
No. And that is true.
our group is really committed. We all still, do assisted deliveries from below, which a lot of places don't do anymore. We are really a group practice that's committed to not doing C-sections. I mean, we're also committed to healthy babies, and sometimes there are situations that require a C-section, but it's really not as often as people think. And right now, the situation in the hospital is good. Overlake has one of the lowest transmission rates in at less than 1% or less than 1%. I mean, so few employees have gotten COVID. It's just we're all masked, and all of us are wearing eye protection and masks, and half of us are covering our have hair coverings on. And I mean, it's really everybody's getting tested for COVID on admission so that we can isolate people who are maybe positive but not symptomatic so that we don't spread it around the unit. It's very, very safe. And that's really the safest place for people, to be. If you're somebody who should not be having an out of hospital birth, don't try to have an out of hospital birth just because of COVID. That's not a good idea.
And the other thing is too is you don't always know what everybody has been doing. A lot of people they want to have all their people at their birth, right? And so right now you can only have 2 labor support people at Overlake.
But you can have 2 now. Yay!
You can have your partner. I mean, you don't have to have your partner, but you can have your partner if you want them there. One additional person. And then, but the thing is I think some people too are like, well, if I need my whole family to be there for my birth and it's a family situation, and we totally understand that. And we are also sad that is not safe right now. But you also have to remember that you don't necessarily know, unless you're all quarantining together, if grandma and grandpa and great grandma and your aunt and, your cousin are all there for your birth, where did they just come from in the last 2 weeks? Have they been with you for the last 2 weeks? So you come into the hospital and we are all masked and everything, but at home, it's very unlikely that people are going to be doing that. So, it is slightly, potentially even a higher risk than what we can offer at the hospitals right now. So, like Dr. Brown said, you have to be a good candidate to have a home birth. And there are definite statistics that suggest that there are increased risks with being at home. Not to say that people should never do it, but adding in kind of not knowing who's going to be there and what that, or even what you got to think that is that birth attendant going to be somebody who's in a mask like we would be at the hospital? Because even though we don't make you wear a mask while you're pushing, we're all protected. And if your birth attendant is not doing that and she just came from 3 other houses that week, potentially it's a little bit of a higher risk.
Yeah. And I can attest to the fact that you guys will try and get a baby out. I can't remember I think I ended up cycling through all of you, but it was 60 hours. We did a 60-hour birth. I was like, cut the baby out of me. I'm not even pregnant. But I was like, for the love of God. And we're like, okay, let's try this. I was like, I mean, just the patience of Job. And I think that's what a lot of patients are kind of fearful of with the stigma that has been put out around there. And with the Perfect Push, we've been very, very intentional about making sure that as a doula company, we work well with physicians, because when we work together well, it is magic for our patients. They're like, what is happening? I'm like, we just work well together.
We just had magic, Rue, like last week.
I know.
It was amazing.
A little props to you too, and what you guys do in your
seriously.
I have never at any point in my entire Keely, how long has it been? 2000, almost 20 years that we've been doing this. Ever had when somebody says, "Oh, what do you think about doulas? Should I get a doula?" I'm like, you should absolutely get a doula, and you need to call the Perfect Push. I've never been able to say that because in the past, I didn't know who they were going to find. And I mean, we've had people come in and the dad is at the side of the mom and the doula's asleep on the couch. I mean, you guys are amazing. And I know that between our nurses at Overlake, who are really well trained and really good at trying everything they can to get babies to turn and move and get that baby out, and then having you there and then having us there, I feel like there is no better trio of things to hopefully get whatever birth experience it is, that the patient wants. But the Perfect Push has just been amazing. So
Magical.
No, thank you guys. No, we love working with you. And I think I envision a world where a lot more doula practices and hospital systems can just do more of this because, when we all know where we're coming from, we all respect each other's boundaries and space.
Yeah.
And we can collaborate. We can actually sit there and go, okay, this is what we can do for the best interest of the patient. Magic does happen. Absolutely.
I think it's true. And I think, some of these ideas that people have about why, we do C-sections or don't, I mean, we don't, it's not solo practice anymore with us. And so we just move from shift to shift to shift. And if somebody hasn't delivered a baby, it moves on to the next doctor, the fresh doctor, the one that's gotten sleep. Right. And so nobody's like doing a C-section because they're running out of the office and they're too busy to, to stick around and try to get the baby out vaginally. If I have somewhere to be, then the doctor on call takes over so that the patient gets the best care that the patient needs. And that it works both ways because the patients get what they need and obstetricians have lives. And so it makes us happy, which makes you happy, and everybody's happy because everybody feels fulfilled and they're getting what they need.
And the hospital will do that too. When there's been a nurse who's been pushing with you for like 2 hours and everyone in the room is exhausted, they send in somebody else. And it's not just like a break. They literally send somebody in to say, we need fresh eyes on this situation. We need some energy. Bring somebody else in.
You just change it.
Yeah. And the nurses actually also have done some really great classes, in terms of rotating babies. They're flipping women in different positions and trying to get the baby to rotate. And they're, a couple of them are really good at one thing or another. And they'll say, oh, go get this nurse because she's really good at this. And, the nurses are really excited now to really try to get babies out vaginally. Overlake is really working on lowering their overall C-section rate. It's really, I think it really shows. There's a lot of pride. We're really excited about what we're doing over there.
Awesome. We have a question from Adrienne Livingston who wants to know how you're advising that your patients manage visitors after they get home with their babies, especially if relatives have to travel via plane.
Oh, where are they coming from is really the question.
Texas. Let's assume they're coming from Texas or Florida.
Give them 2 weeks and stick them somewhere else for
it's hotel room.
It is a tough situation, and I think if they are and to get tested right now, and Dr. Brown, you might be able to help me with this because I know that one of the docs in our group is working really hard to figure out where people can get tested and what the turnaround times are. We have somebody on that right now, but really, I think you've got to be careful depending on where they're coming from. And looking at the number of cases in the area and looking at what they've been doing. I keep saying that, but are they going out to the grocery store? Are they having, are they working? What kind of population are they working with? Because if they have a pretty good chance of being a carrier or and even an asymptomatic carrier, or actually having it and not being sick yet, because, it takes a couple weeks, you may want to have them come out if they can ahead of time and stay in a guest room and use a side door, just until you give it a little bit of time. In a normal situation, I think, if you were just a young family, you could probably take the risk. But if you're having a baby, I feel like you got to be a little bit more careful.
Yeah. I think, the days of everybody coming over to see you and kind of parading past the baby are sort of over for a while. I do think that, so Adrienne looks like she says Pennsylvania. So that's a better part of the country than Texas or Florida. And, so I think it's about, are they masking? Are they limiting their movements when they're before they come? And then obviously there's going to be a risk of exposure on the flight. And so I agree with Dr. Gallagher. I think that, maybe not having them run and kiss the baby the first thing as soon as they walk in the door, but really maybe getting a test and having them just sort of isolate a little bit when they get there. And then if everybody's negative, then it's wonderful and you can just be. And I've said this to my patients a lot. I think that, people are really worried about family and even not traveling, just local family. And we have these conversations and I do think that there is a human and emotional impact to all of this, and that you can't underestimate that. And we talk about, just like mental health is a real disease. It's a real, it's a real medical problem when it goes wrong. This, I think, is something that we can't underestimate, that people can get depression and can feel really badly from being isolated from their families, and that can make for problems in their pregnancy, just from not being well. And so I think that you have to, it's not about taking risks, but it's about weighing how you can best get what you need. And if it's seeing your family in your backyard and being careful, then that's what you need to do. And maybe it's not being totally alone all the time. And that's a small risk, but it's a risk that's worth taking, because that's what you're going to need to get to the next step to feel better.
And I think too, one thing you have to realize is a lot of people are very worried about, how I'm not going to have help, and I'm going to be, having to take care of the baby by myself and take care of me. But honestly, I think studies are going to show that for the baby, it's great. They love it. They have, they have their mom and their dad, and that's really all they need. And it's really the mom maybe that could use the extra hands in the house. But if you look at, they've even talked about how, kids being at home, it's really, really hard. I have 4 of them, like really hard, but it's actually kind of good for them. They're getting more attention. They're seeing each other. They're seeing us. It's good for pets. Like, pets are super happy right now. There's a lot of things about this that, as hard as it is, there's a lot of really big benefits to it. And I think you just kind of have to make lemonade out of lemons, right? I mean, you have to make the best of it, and you have to realize that for the baby is going to get so much bonding with just the mom and dad, which is really what they need. Sometimes all these grandparents come in, they're so great, mom hardly touches the baby because it's on grandma the whole time. And there are benefits, is all I'm going to say. Like, there are downsides, but there are definitely benefits.
Okay, so Dionne, my mom is watching. Mom, she's not talking to you at all. She is not talking to you. You will hold the baby when I have one all the time. Okay, I'm like, can you stop talking now?
Your mom's like freaking out now.
I'm like, you're messing up a good thing. Like, literally, my mom is like my child.
No,
she's like, Dr. Gallagher said you can do this on your own.
No, but the baby doesn't know. It's only us that know. So unless baby's happy. Baby has lots of mommy and daddy.
No, I love it. I think those are some of the things that have come up with COVID that, the silver lining in very, very dark clouds is even I'm home so much more, and I get to see my little people so much more. I get so many more cuddles. It's definitely made a big difference. But I want to make sure that we get this in, because this is something, and Keely, you called me right when the whole George Floyd incident happened. And when George Floyd died, and I had all my white friends calling me and messaging me and saying, "Are you okay?" Da, 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 da. You were one of the only people who called me and said, "Rue, what are we going to do let's not forget about Black women dying giving birth."
Yeah.
And I was like, right? And now we have COVID. And I'm doing a study with the UW, and just listening to the stories that women of color are facing in hospitals here on the East Side in Seattle. There are not many of us, but in hospitals here on the East Side, I'm like, ladies, what do we do about this? Like, we're seriously dying out there, just trying to have that, that experience that I think everybody should have, and it should not be a matter of life and death.
It should not. And I don't even know. I mean, I know, but I don't know. I mean, we need to be better. Is the answer. We need to make women feel safe. I can't imagine, and I feel like I'm pretty, forward thinking on all of these things. And I can't imagine somebody coming into our practice and feeling uncomfortable or feeling worried that they weren't going to get the care that they deserve or that they should have just because of the color of their skin. It's mind-boggling to me. But I know it's so much bigger than me or you or Dr. Gallagher, or, it's everything. It's institutional. It's everywhere that we are. And so it's about not allowing that to enter the conversation, not allowing that discrimination to even enter the conversation. I think it's going to take a lot, it's not just enough to have a couple of doctors be like, yeah, we love everybody, because we do, and I trained in Center City, Philadelphia, with a very different patient population than we have here. And it actually was better there in some ways, because I felt like nobody stood out. I mean, everybody, there were lots of things that were wrong, but in some ways there were services available and things that we could do that were not so hard to come by like they are here. I mean, I feel like everything here is a struggle with that. And so I do think it's something that we need to work on, but I don't have good answers right now.
I know I think we live in a bubble on the East Side where we just don't have a lot of women of color. And when I do, talk to women of color, or even just listening to the stories and the studies, and I had a patient the other day who said to me, they kept on asking me, what brings you here? Why did you decide to deliver here? Oh, where are y'all from? And it was like, huh?
Yeah.
And you just hear these stories and you look at the statistics, and I'm tired, but at the same time, I'm like, we can't be tired, because this is not going to change unless we do something. So I'm so glad that you're thinking about it. I remember when you said, I was like, oh my God, dude, what do I do?
You were the first person I thought of. Like, honestly, there were like I have lots of people in my life who I thought about when all this happened, but you were one of the people I thought about, because it really ties directly into this conversation. How can I make a difference? Well, I'm a white girl who lives on the East Side, right? I mean, and what can I do? Well, I can be better about how I take care of my women, my patients who are of color. That's what I can do.
Yeah, and I've actually had patients ask me, some of my African American or women of color, ask me why those statistics are what they are, because it doesn't always just chalk it. Per the study, it doesn't, the big one that was recently done, it doesn't chalk up to just, maybe higher risk of diabetes or any kind of medical condition. And it's really baffling to me. And personally, I'm a Montana girl. There were 3 African-American kids in my whole high school, my whole graduating class of like 500. And I have never understood, even being from such a white place, like it doesn't get much whiter than Montana, why it matters. And it wasn't like my parents were ever like pushing it down my throat either. I just never understood why it matters what color we are and why people would need to be treated differently. And that's always really, really bothered me. But the study that have shown that there's the higher risk. It's very interesting to me, and I wish we had answers to it. And it makes me frustrated, and I just hope that anyone coming to me or knows that I'm going to treat everybody the same, and I'm going to be a little bit more on the lookout, because we know that the statistics exist in that, especially in that population. And I wish we could figure out why that was the case, and put a little bit more light on what we could do differently to make women of color feel safer, I guess, especially when they're going through a really important time in their life.
And to be an advocate, right? And to I mean, it's really because I think that the hard part for me is that I know how I feel.
Right.
But how I feel, I'm not the only person that they see and that they talk to. It's important to me that in our office, it's important to me that every person that you communicate with, from the front desk to our nurses to our MAs, and then when you get to the hospital, there's all of the people that you meet at the hospital. So while it's important how we do and how we advocate, it is so much more than that. And I think that's the systemic part of it that is bigger than we are. And I have not yet figured that out, how I'm going to make that better. But I know that I can start small, which is with my practice, our practice, and in our hospital, creating a culture. I correct people all the time or I am at a place now where I've been at Overlake long enough that I don't really care if I offend somebody. And I'm happy to call people out if I feel like they are being unfair or they're making a judgment potentially about something that maybe they shouldn't. And you know what? Every single time I've done that, people have kind of reversed course and been like, you're totally right. And I know that the potential is there. I know that it can be. And it's just a matter, I think, of calling, as Dionne said, as Dr. Gallagher said, bringing light to it, showing people, calling them out, making them aware, because I think sometimes you're not even aware, which is even 10 times worse.
Yeah, I think the implicit bias that go on, because the one thing that I wish, and the one thing that I want to see change is I want to see more providers of color. I remember being 27 weeks pregnant and finding out I had an incompetent cervix, and I went to Eastside Maternal Fetal Medicine. And when I walked in, the sonographer was this beautiful Black lady, and she goes, "Baby, you're gonna be." Like, she spoke to my soul in a way, and I know how to advocate for myself. Like, no one is pushing me. Like, I'm not gonna fight today.
Not worried about you.
Like, I was like, what do you mean? I was supposed to be on a plane the next day to go see my mother-in-law who had cancer. You're telling me this baby's trying to come out. My husband is, 48 hours away by plane. Like, what do you mean? And to just see that woman, and I tell you, she was like, "Nope, you need to see this provider. I want, who are they bringing in here?" And it was just having somebody who looked like me, who saw me, who understood me. And I think if we're going to change the statistics, we need to be having conversations like this on a peer-to-peer level, and not necessarily provider patient. So when you see me and you're like, "Oh, Rue, that's my niece in there," because y'all know I'm praying for a baby girl. So you can be like, "Rue, that's my niece in there, so we're going to take the best care of you." It's because we have that relationship. And until we have more people of color everywhere and at every level, I don't know if this is going to change, despite anybody's good intentions.
Yeah, I know. And I mean, personally, I completely agree with you. And I wish we had more diversity in the medical staff, and especially within our physicians, to be honest. I really love the diversity in the staff because it does make everybody feel a little bit more comfortable. But also, I think going back, it is hard, definitely patient to provider, because that's all we have right now, because we can't, we can't make them come. Maybe you can.
What? Stop the rain. We don't like the rain. The rain is wonderful here. Seattle is it's a lot for people of color to have to deal with this weather.
I know. And if that was one thing I could change about the diversity in this area, honestly, I've said it to my kids, I've said it to my husband, I've probably said it to Keely or Dr. Brown, but I wished we had more people of color in this area, honestly. That is something I think we are missing. And that's just how I've always felt about this area. But for the patients as well, I think the hard thing for me as a white girl provider is that I never know if I can bring it up, if I can talk about it without offending. I would love for them to bring up that they have concerns about that, or to be able to talk about it, because it's always really hard, especially right now, is because of everything that happened with George Floyd. And it's like, I had patients come in. I have several patients of color, and they're some of my favorite patients. And I just didn't know what to say, because I didn't want them to feel like they were different. I always just try to treat everybody the same, right? And so I felt like, well, if I bring it up, am I just making them feel, like they are different, because I don't see them as different. Do you know what I mean? So I think that is just my only word to those patients are, if you want to talk about it, talk to me about it, just like people talk to me about every other really, really personal thing in their life. I mean, that's the beauty of a gynecologist. There is nothing you can say that can surprise us.
Right.
You've seen it all, literally.
Which is so weird that this is a thing that's hard, right? Because I talk about all sorts of stuff with people all the time, and this is definitely a barrier. I mean, it's definitely something. I mean, this and like weight potentially. Sometimes, sometimes during pregnancy, not all the time. Sometimes I can look at somebody if I've known them a long time and be like, but sometimes I'm really careful about it. And I think, and I think Dr. Gallagher is absolutely right. This is one of those things that's really hard to navigate, because if they're afraid, I want to know they're afraid so that I can be that advocate for them. But I feel like there's a lot of self-protection, right? And they don't want you to know that they're afraid, because that's weakness.
And they don't want to be seen as different or treated differently. So it's like, you're damned if you do, you're damned if you don't.
Right.
Yeah.
And so I definitely think that's a a thing.
Yeah. And we definitely have, we have, because of Microsoft, we have people from all over the world, and we definitely have, some people. I have several patients from Africa who are directly from African countries, and that is just super interesting, as is
Cool.
every patient from all other parts of the country. And, we often talk about that, and, where they're from and how they came to be in Seattle. And it's often because of, work in some way, but that opens the door a little bit to those conversations. But again, I just really don't always know what's going to be offensive, because I don't want to point it out. But if patients ever want to talk about it, that would be my way of, saying, please talk to me, because I probably want to talk to you about it, because I don't know what it's like to be in your skin. And,
Well, I can safely tell you right now, as a woman of color, I think it's all in our minds. And I think a lot of us don't want to say anything, because just like you're like, I don't want to offend you and make you feel like I think there's something going on with you, or you might be biased against me, so I may not bring it up. But I almost think you can almost always, say to a woman of color, I know what's going on. I'm aware of that. That would be so comforting to me for my provider to say, you know what? I am aware of the statistics happening right now. I'm committed to making a change. So if there's ever anything that comes up, or anything that I do, or anything that happens within, our practice that makes you feel as a woman of color that you're unsafe, I want you to know that you can talk to me about it. So I think that would be, just before we even get into anything, I don't even know where you're coming from. I don't know what you're worried about, but I want you to know who I am and where I'm coming from. I think just leading that way, I think right now, as people of color, that's how we're needing everybody else to show up and just say, I know it. I know what's going on. I'm not ignorant of it. I'm not going to pretend that there isn't a big elephant in the room. And I'm here for it all day, every day. Just knowing that, we've got you on our team, and you get why I might keep stuff away, because I feel that's when people keep stuff away from you. Right. And that ends up compromising their care.
Yeah. Because maybe it's going on in their family. I mean, you don't know. Maybe someone in their family has been very affected by the situation that has gone on, even down just recently with CHOP and Capitol Hill, and having, being out protesting, and maybe they've had something very personal happen, and they don't want to talk about it. So that's a good way to say it, is to just acknowledge that you're here to talk about, is it whatever it is related to current events and things
that are ever changing. And it's,
I know, but every time people come to ask me about something like COVID, with COVID especially, I'm like, well, I want to tell you, but I'm going to give you the disclaimer that, like, it might change tomorrow. So I'm going to give you my best information now.
Exactly.
Especially when people ask me
what's going to happen. Thing is new to me. I'm like, what do you mean there's vertical transmission? Like, what? I thought we were saying there wasn't. And now I'm like, oh, whoops. Okay. I need to be telling our pregnant moms that no.
It just literally, like, maybe a day or two ago, this all came out. And, we have a little chat amongst the docs in our group where we talk to each other sometimes. And, that headline came out, published in Nature, and also ACOG came out with a statement. And it's definitely a thing. So.
Wow.
And then the big question often comes up too, just as, can they be with their baby or not? And we don't have answers for that.
So many things that we don't have answers for.
We don't know. And they have a right to choose what they do as well. Nobody's taking their baby away. And I think that's important for everybody to know. So they would have the option to have that happen. They would also have the option to just go on as normal. So.
Awesome. Yeah, I think a lot of people have been concerned, if I have COVID, are they going to take my baby away? If I go to the hospital, they're going to take my baby. I'm not going to see my baby. So again, Dr. Gallagher is saying nobody's trying to take your baby away. Nobody is going to take your baby away. So that is not the policy currently at Overlake or within their practice.
And we've seen very, very little. I've delivered very few patients. I mean, under a handful that have either had it during the pregnancy and have now recovered, or have it during. I have not delivered anybody. I've taken care of patients that have it, but very, very few. I mean, it's very uncommon in what we do every day.
I think because inherently women who are pregnant are extra careful, which is spectacular. Like, great. I'm super happy that we have women who are nervous about everything, because this is actually a great time to be nervous about it, right? I mean, this is the thing I want you to be nervous about. Yeah.
And just another really important thing, and one of the people that I have taken care of that had it, the entire family got together for a barbecue for an event, and the entire family got it. And so that just goes to show that when we say you can't do that, you can't
mean it. You really can't do it.
You really want to, because they were all family, right? But they hadn't been around each other in months, and they all came together, and everybody got sick. So
I know, just when you think you can, you can relax, you can let loose. And we see it with all the states that decided to open, and now we're rolling back and shutting down.
Yeah.
So yeah, it's like, this is take a step back and go through the process. It's a process. It's painful. And I think, Keely, you said it best, like, we're all tired of it, but it doesn't change the fact that it's here. We still have to be very vigilant about everything.
And with
Ladies, I feel like we could talk forever.
I know. Yeah.
I seriously, I love chatting with you guys. But I want to make sure that we get in a few things about Bellegrove so people do know a lot more about your practice. And you guys have women's health nurse practitioners, specializing both in adolescent and adult women's health. You've got aesthetics. In fact, that's part of the gift basket that you guys are giving away. So Bellegrove is going to be giving an amazing postpartum survival gift basket that has books, including a new millennial mom's book called Bumpin'. Dr. Brown was just telling me about that. I can't wait to go and do some research on that, a postpartum belt, and then a gift certificate to see one of their estheticians, which, I just, thank you guys. Thank you. But tell us, outside of delivering babies, what else can people expect when they come to your practice? What else are you guys offering?
Well, I can take that one. So there's, we obviously do complete GYN gynecological care. So that includes anything from contraceptive management, adolescent care, abnormal uterine bleeding is a big one. We actually do all in-office procedures. So you don't have to go to the hospital and pay for an anesthesiologist and deal with all the hospital stuff. You can come straight to our office and you can have procedures to help you with your bleeding. We do all usual contraception, IUDs, Nexplanon, obviously hormonal management for menopause, some infertility treatments before it goes on to invasive treatments. And then, just a little added benefit is we do have the aesthetics practice. I'm actually the medical director for the aesthetics practice. And the two estheticians that we have are both former postpartum nurses that I believe Rue also knows. They're absolutely wonderful. They are moms, and they took care of women. They became, postpartum women for years, and they realized kind of the aftermath of what that does to the female body, and decided that they wanted to be on the side of, kind of helping moms feel better, because there's no worse time in your life, and having had 4 children, I know, than the first 6 to 12 months after having a child. Aside from all the wonderful things about the baby, seeing what happens in your body is really challenging. And, being able to, for both Kat and Rachel, our estheticians, to, to go in and see them and just do something that makes you feel better is good. And it doesn't have to be anything long lasting, but just a facial, or, having somebody evaluate why it is that you're still leaking 12 months after your delivery, and provide you with a treatment that's non-invasive for that. And they do offer some vaginal treatments for anything from sexual dysfunction and problems with not pain, but problems with function after delivery, as well as incontinence and laxity issues. So there's lots of good things that they can offer. So, I feel like we have a very, very well-rounded practice at Bellegrove, and we basically offer everything, including minimally invasive surgery if we do have to go to the hospital. So it's all inclusive.
I love that. Yeah, I wanted to make sure that we got that in, because I'm like, you guys do so much amazing stuff in one place. So to be able to have your babies, and then after you have your babies, to still be able to get, taken care of all the way through menopause, you don't have to change your doctor. It's like you've got it all in one place. So I absolutely.
The other thing too, all in one place, is we have a lab in our office, and we also have ultrasound. So even when you're pregnant, you don't have to go to the hospital and have your ultrasound there with somebody who's very not that Overlake is wonderful, but it's still going to be an impersonal experience. Oftentimes, we have patients that see our ultrasound tech so much that they're like, oh, I only want to see Teresa because she sees me every time. Like they actually know her name and she actually talks to them through their whole ultrasound. Or, you're not going to get that when you don't have that in your office. So I think it's a benefit.
Perfect. And then insurance-wise, what insurances do you expect? Do you accept any insurance restrictions with your practice?
We accept almost everything. I think, and even Kaiser, the PPO, I think we take the one that has the extra choice. But there aren't a lot that we don't take.
I'm not sure on
TRICARE.
Very, very few patients that are ever military and on TRICARE. I'd have to ask our billing department on that.
But really, there are very few restrictions. We tried to accept as everybody and anybody that wants to come see us.
We always offer, if somebody doesn't have insurance right now because they've lost their job and they just need to get in for an annual because they have maybe a history of an abnormal PAP, we do have just very reasonably priced cash pay offerings as well. So if you just need to get in and you don't have it, insurance for the next 6 months or whatever, you just have to call and ask.
We find a way to work with you. I mean, we want to make sure we are fundamentally committed to caring for women, and we try to make it so that it's not an issue as best we can.
Why you're two of my favorite people. Well, ladies, my husband just got home, and since you guys gave me the green light to have a baby during COVID, I got a baby. My poor mother, she was so mad at me. My mom was not talking to me when I got home the other day because she was like, why would you talk about trying to get pregnant on Facebook? You are an African woman. Don't forget your roots. We don't talk about, you tell people when the baby shows up. I was like, so, yeah.
Mothers, they're good for, they have a lot of good advice.
And meanwhile, I'm sure
I'm about to take you out of this broadcast. I'm like, seriously? You're not helping my cause here.
No, because your mom is there. Is your mom there now?
Yes, watching.
She's watching.
Okay. There we go. Mama's watching.
How would you be who you are, the wonderful person you are today, Rue, without her? Because she must have some contribution to that.
I got my oversharing from somewhere. That's all I'm gonna say.
we owe a lot to our mothers.
Yes, we are.
Yeah.
All right, ladies, I'm going to let you guys get to your little people. Thank you so much for joining me. I will make sure I share this broadcast with you and we'll push it out there. There's so much information. We could have gone on and on. So many other things I wanted to talk about. So hopefully we'll be able to get you guys back.
Yeah,
absolutely.
Absolutely.
All right, ladies, have a good night. Everybody, thank you so much for watching. We're going to put the link for the giveaway. Please make sure you enter the giveaway. We're going to announce the winner on Monday by 9 a.m. Again, it's a postpartum gift basket, all thanks to Bellegrove OBGYN. Their favorite things, favorite books for you guys to read, a postpartum support belt, a trip to the esthetician's office so that you can, just get a little bit of loving and self-care. So thank you so much for watching. We'll see you guys next week. Bye.
Bye.